So we started with basics of ECG. We finished about the rhythm disorders and we finished about the rate. Now we'll discuss about the other waves. So about the P wave disorders, right atrial enlargement or left atrial enlargement. So I told normal right P wave is 2.5 small squares horizontal and 2.5 small squares vertical. So suppose if it is tall in lead V2, then it is called as P pulmonale. So normal lead V1 is usually biphasic. P wave in lead V1 is usually biphasic. So if the initial wave is tall, it suggests right atrial enlargement or P pulmonale. Left atrial enlargement is called as P mitral. So here in lead 2 we get bifid broad P wave. And in lead V1 we get a negative, predominant negative wave of P wave. So what conditions cause right atrial enlargement or left atrial enlargement? They are valvular heart diseases. So basics of valvular heart disease. So understanding the basics is simple. So you can draw the diagram of the heart, box diagram. This is right atrium, right ventricle, left ventricle. So tricuspid valve separates right atrium from the right ventricle. Right ventricle empties into the pulmonary artery. Pulmonary artery is a high capacitance, low pressure system. So the oxygenated blood from the pulmonary circulation through the 4 pulmonary veins enter into the left atrium. They empty into the left ventricle by the mitral valve, and the oxygenated blood goes into the aorta through the aortic valve. So we discussed about the cardiac cycle. So assume that one valve is problematic. For example, there is a mitral stenosis, which is the prototype disease. When mitral stenosis is there, the mitral valve is less than 4 centimeters square. So when the mitral valve becomes short, what happens? The blood finds it difficult to move from left atrium to the left ventricle during atrial systole. So atrial systole is actually ventricular diastole. So mitral stenosis is a diastolic event. Blood finds it difficult to move from left atrium to the left ventricle. So when it happens, what happens? There will be reduced flow to the aorta. In due course, left atrium becomes dilated. The back pressure gets transmitted to the pulmonary veins, to the pulmonary capillaries. So when pulmonary capillaries become leaky, there will be pulmonary edema. Chronic pulmonary edema leads to hypoxia. Hypoxia causes vasodilatation everywhere except in the lungs, where it causes vasoconstriction. So it is called as pulmonary vasoconstriction. When pulmonary artery goes for vasoconstriction, its pressure increases. So it leads to pulmonary hypertension. So now the right ventricle has to pump more against this pulmonary hypertension. So it will go for right ventricular hypertrophy. When right ventricular hypertrophy occurs, back pressure goes into the right atrium. Any right atrial pathology will lead to changes in JVP. So likewise, you can frame for any valvular heart disease. What happens in regurgitation? So I'm not drawing here, I'm just only telling. In mitral regurgitation, there is a leaky mitral valve. So normally during isovolumetric contraction, when ventricle contracts, blood does not flow back into the left atrium. Instead, the increased pressure during isovolumetric contraction opens the aortic valve. In mitral regurgitation, the mitral valve becomes leaky. So during ventricular contraction, blood leaks back into the left atrium. So left atrium slowly enlarges, and the excess blood from the left atrium comes again to the left ventricle during the next cardiac cycle. So LA and LV both will be overloaded in mitral regurgitation. So what happens in aortic stenosis? Again, aortic stenosis is a systolic event. Normally blood flows from the left ventricle to the aorta. So when aortic valve is stenotic, blood finds it difficult to move from left ventricle to the aorta. So now the left ventricle has to go for hypertrophy to pump blood against this stenosed aortic valve. So AS is usually told when it is less than 2.5 centimeters square. So excess LVH, again left atrial dilatation, pulmonary hypertension, the same pathology. What happens in ER? Normally, during ventricular diastole, blood should not flow back from the aorta to the LV. But when aortic valve becomes leaky, during early diastole, during isovolumetric relaxation, blood flows from the aorta to the left ventricle. So again, LV becomes overloaded. So MR and ER are volume overloaded conditions. So volume overloaded conditions lead to high output cardiac failure. Okay, so likewise you can frame. So whenever you are thinking of any valvular heart disease, always we classify the severity. So one important point to tell the severity is presence of symptoms. Any symptomatic valvular heart disease is severe, right? And it needs treatment. Plus we have many echo criteria, vascular Doppler criteria. We are not discussing it here. Just if one thing you have to remember, symptomatic valvular heart disease needs treatment. Okay, if time is possible, please you can go through the severity criteria. I will discuss the causes. We'll discuss the treatment initially and go to causes. Treatment is simple. If the patient is symptomatic valvular heart disease or has a severe heart disease, they need surgery. So surgery for stenosis, they usually open the valve. So for mitral valve, they say it as balloon mitral valvotomy. Or in severe cases, they replace the valve. So mitral valve replacement or an aortic valve replacement. If there's a regurgitation lesion, they usually repair the valve, mitral valve repair or aortic valve repair. We have TAVI. It's a minimally invasive procedure. So we'll discuss mitral stenosis. From time again, we have been discussing rheumatic heart disease. Okay. There are congenital causes, etc. Mitral regurgitation always classify into acute and chronic. Why acute and chronic? When mitral regurgitation is acute, infective endocarditis or papillary muscle rupture in MI. These are two important conditions which cause acute MI. In papillary muscle ruptures or when there is a leak through the mitral valve during infective endocarditis, what happens? Blood from the LV goes into the left atrium, but the left atrium will not get distended. Whereas in chronic, when this process occurs again and again, the LA will get distended. So since the left atrium is not distended, the pressure will be transmitted very much. So patient will be very sick and very symptomatic. There will be very severe acute pulmonary edema in acute MR. So two important conditions are infective endocarditis and papillary wall muscle rupture in post-MI. Whereas chronic, we have so many reasons. Again, rheumatic fever is a cause. Remember, mitral valve prolapse is one cause of myxomatous degeneration. And some condition, dilated cardiomyopathy, ischemic cardiomyopathy. When LV dilates, it causes secondary MR. Aortic stenosis, only three important causes. Young age, it is congenital. Middle age, it is rheumatic fever. Old age, it is degenerative. Aortic regurgitation we can classify as valvular disease or aortic vascular disease. So here again we have congenital causes, rheumatic fever, myxomatous, syphilis you can remember, and aortic root disease or aortic dissection, and we have cystic medial degeneration of the wall, some vascular disease like Marfan's, etc. Pulmonary and tricuspid valve diseases are not very common. So usually right-sided heart diseases may be carcinoid syndrome or congenital usually. Tricuspid again, carcinoid, rheumatic is very, very less common. Okay. So we discussed about few causes, the pathogenesis, the treatment. Some questions may come on murmurs. So 4 valvular heart diseases are common. We have pansystolic murmur in mitral regurgitation. Why systolic murmur in mitral regurgitation? Because MR is a systolic event. Aortic regurgitation is a diastolic event. Okay. What about aortic stenosis? It is a systolic event. So it causes ejection systolic murmur or a mid-systolic murmur. What happens in mitral stenosis? It is a diastolic event. So it causes mid-diastolic murmur. So mitral area, we commonly hear only two murmurs. Either diastolic murmur could be mid-diastolic murmur, or the systolic murmur could be pansystolic murmur. If we hear a mid-diastolic murmur, the diagnosis is mitral stenosis. If we hear a pansystolic murmur, the diagnosis is mitral regurgitation. Aortic area, again we can hear two types of murmurs. One, ejection systolic murmur. It is in aortic stenosis. Early diastolic murmur. This is usually better heard in the second aortic area. Aortic area, second aortic area depends on vascular cause or valvular cause. So this will be in aortic regurgitation. So we are not discussing more than this. There is something called as dynamic auscultation. So usually when we stand, what happens? The blood flow to the heart reduces. When blood flow to the heart reduces, the intensity of murmur reduces. So see, with standing, most murmurs diminish. The same thing is with Valsalva. When we blow against a closed glottis, due to increased intrathoracic pressure, venous return reduces. So when we do a Valsalva or when we stand, all murmurs will decrease. But remember we discussed about mitral valve prolapse. Two conditions are there which behave opposite during dynamic auscultation. Those two diseases, one is HOCM. HOCM is hypertrophic obstructive cardiomyopathy. HOCM is like aortic stenosis. It causes ejection systolic murmur in mitral area or the entire heart. Mitral valve prolapse causes mitral regurgitation. It causes pansystolic murmur, plus there is a click which is heard. So click followed by a systolic murmur in the mitral area. These two behave differently. So when all murmurs decrease with Valsalva or with standing, the click followed by systolic murmur of MVP and the systolic murmur of HOCM both increase in intensity. So that's what is VAST. VAST means increase. So in HOCM or MVP, during Valsalva or standing, the murmurs increase. Hand is during hand grip, all murmurs will increase because on doing hand grip, the peripheral resistance increases. So the turbulence should increase because of pressure difference. But in HOCM and MVP, on doing hand grip, the murmur reduces. So why it occurs is because of the pathophysiology. See, this is a normal myxomatous degenerated mitral valve which prolapses into the left atrium. So when it prolapses, there is a click and there is a regurgitation. On standing, what happens? So on standing, left ventricular volume reduces. So there is more chance that this mitral valve may prolapse. So during standing, we discussed when prolapse is more, murmur increases. Okay. So we had discussed it separately in one discussion. So what is this disease? Hypertrophic obstructive cardiomyopathy. So how does hypertrophic obstructive cardiomyopathy differ from other conditions like hypertension or AS? Everywhere there is hypertrophy, but in hypertension or AS there is a diffuse hypertrophy, the entire wall including the apex hypertrophies. In hypertrophic obstructive cardiomyopathy, we have asymmetrical septal hypertrophy, asymmetrical septal hypertrophy. Like here, see the apex is not hypertrophic, only the septum is more hypertrophic. And the second feature is there is SAM. So if you get a video based question, they may give this picture. They may give picture A, where this is the mitral valve. It flailly moves up and down during systole. So that is systolic anterior movement of mitral valve. So how will be the presentation? A young male who presents with sudden cardiac death, and there is usually a family history. So this is hypertrophic cardiomyopathy. Okay. And treatments, in it causes sudden cardiac death, implantable cardioverter defibrillator is the treatment. It is preventive measure, usually beta blocker is given. Sometimes the hypertrophied septum is surgically removed. Now, so we finished about dynamic auscultation discussion of valvular diseases, and coming to about two important diseases which we discussed. We told infective endocarditis is one condition which causes acute MR. So just a few important points. So infective endocarditis is nothing but infection of the endothelium or the heart valve. Infection of the endothelium or a heart valve. So valve can be normal person's valve, that is the native valve. So that's called as native valve endocarditis, or it may come in a prosthetic valve. So prosthetic valve endocarditis. So native valve endocarditis may be community acquired, or it could be healthcare acquired. Healthcare acquired usually occurs following needle prick or needle insertion following a improper sterile technique. So prosthetic valve again is classified based on the duration, like when it comes less than 2 months, 2 to 12 months, and more than 12 months. Okay. So just know the common organism. So overall, in community acquired, Streptococcus group is the most common. So community acquired native valve endocarditis is usually by Streptococcus. Native valve healthcare associated, as I already told, it is by improper sterile technique due to needle insertion. So it is due to Staph aureus. So native valve community acquired is Streptococcus, and native valve healthcare associated is Staphylococcus. And what about prosthetic valve insertion? Prosthetic valve endocarditis less than 2 months. It is again Staphylococcus, especially coagulase negative Staphylococcus. 2 to 12 months also it is coagulase negative Staphylococcus. Okay, so suppose more than 1 year, prosthetic valve endocarditis will be similar to the community. So it will be Streptococcus group, like Streptococcus viridans. Okay, so native valve endocarditis, Streptococcus. Healthcare associated native valve endocarditis, Staphylococcus aureus. Prosthetic valve less than 1 year, coagulase negative Staphylococci. More than 12 months, prosthetic valve endocarditis is again Streptococcus. And maybe this point you can remember. Enterococcus usually causes infective endocarditis in any person for whom urological procedure is done. So this is usually an MCQ. So diagnosis is by Duke's criteria. So there is a positive blood culture with typical organisms. I think this is self-explanatory. Sometimes image-based question they can give the minor criteria, like they can give the vascular phenomenon or immunological phenomenon. See, these are the Janeway lesions, the painful tender oscillar nodes, and this is the nail bed infarct. Okay. There can be conjunctival hemorrhages. Okay, what you see is a septic infarct. Right. So another important cause of valvular heart disease is acute rheumatic fever. So there was the 2015 modified Jones criteria. So what is the organism causing rheumatic fever? It is group A, beta hemolytic streptococci. It is actually an immunological phenomenon due to molecular mimicry, where our immune system attacks our own heart valves due to molecular mimicry with the proteins from group A beta hemolytic streptococci. So the important thing in 2015 criteria is that they have classified the population into low risk population and moderate to high risk population. India is a high risk population. So the thing is, there are 5 criteria: carditis, arthritis, rheumatic chorea, erythema marginatum, and subcutaneous nodules. Among that, carditis may be clinical or subclinical in India. Plus, polyarthritis need not be there. There may be monoarthritis, polyarthritis, or even polyarthralgia. Arthritis is swelling, tenderness of the joint. Polyarthralgia is only pain in the joint. Even polyarthralgia can be taken in India. And even subclinical, that is, there may be only a echocardiographic evidence of valvular heart disease. So even that can be taken as a positive factor. So these can come in clues. So there should be 1 major plus 1 minor, or there should be 2 major and 1 minor, or 1 major plus 2 minor criteria, plus there should be supportive evidence of group A beta hemolytic streptococcal infection, either in the form of ASO titer, or there should be throat swab culture positive. Okay. So this finishes acute rheumatic fever. And this finishes about the P wave discussion in ECG. Now coming to the QRS. So QRS duration we discussed much in arrhythmias. About Q wave height we can discuss. So LVH, RVH, LV failure and RV failure. So this is how V1 looks. So normally V1, the R wave will be small, S wave will be prominent in V1. In V2, the same. It will have a bigger R wave and S wave. V3 and V4 is usually equiphasic. So V3 and V4 is the place where transition occurs. V5 and V6 we usually get tall R wave and a small S wave. So this is the normal progression of QRS. This is the normal progression of QRS complex. So when do we say that there is LV hypertrophy? There are many criteria. Remember one criteria, V1S plus V6R is more than 35 millimeters. So see here, the S wave is very deep in V1. The R wave is very tall in V6. So that is what is V1S plus V6R, because V1 is close to the lead V1 and V2 are placed, V1 is placed in the right side of the heart. So if V1 is tall, it means right ventricle is hypertrophic. If V6 is tall, it means left ventricle is hypertrophic. So V1 will have the opposite of LVH. So V1 has a deep S wave and V6 has a tall R wave. If the combination is more than 35 millimeters or 35 small squares, LVH is there. Opposite occurs for RVH. V1 has a tall R wave. So V1 has a tall R wave. They say more than 10 or more than 12 will be the criteria. So you can just say there's a tall R wave in V1. Is RVH. So conditions for LVH we have just discussed: hypertrophic cardiomyopathy, hypertension, aortic stenosis. So this is about the hypertrophy criteria. Now what about poor progression of R wave? Normally I told V1 will have a small R wave and a deep S wave. V3, V4 will have equiphasic R wave, and V5 and V6 will have tall R wave. So this is a normal progression. Or in other words, people say V3 should have R wave of at least 3 millimeter. V wave should have R wave of at least 3 millimeter. If V3 has R wave less than 3 millimeter, it indicates poor progression. This is exactly what we are discussing. So V3 should have a tall equiphasic R and S wave. When it is not there, it is called as poor progression. Poor progression of R wave indicates left ventricular failure. So that introduces us to the concept of heart failure. So by seeing the QRS complex, we can understand about cardiomyopathy. So there are three types of cardiomyopathy or muscle-related diseases. One is dilated cardiomyopathy, restrictive cardiomyopathy, and hypertrophic cardiomyopathy. We have discussed about hypertrophic cardiomyopathy just now. What are the echo features? Asymmetrical septal hypertrophy, systolic anterior movement of mitral valve, sudden cardiac death, and how will you treat about it? So we will leave off this one. Dilated cardiomyopathy. So there are many causes of dilated cardiomyopathy. Like in ischemic heart disease, the heart can dilate. Post some viral infection, it can dilate, or it can dilate due to genetic reasons. In Chagas disease, there can be dilatation. So ejection fraction is usually low in dilated cardiomyopathy. What is restrictive cardiomyopathy? The heart itself becomes thick. So usually storage diseases occur in restrictive cardiomyopathy. So just about the causes which we are just speaking. Alcohol causes dilated cardiomyopathy. The infective causes, viral, fungal, Coxsackie disease, Chagas disease, etc. cause dilated cardiomyopathy. Thiamine deficiency, like in alcoholics, thyroid disease cause dilated cardiomyopathy. And there are so many inherited diseases like laminin deficiency, and many diseases like Duchenne's muscle dystrophy, Kearns-Sayre syndrome, it's a mitochondrial disease, all cause dilated cardiomyopathies. If possible, read few names, be aware of them. Restrictive cardiomyopathy usually occurs in infiltrative or storage diseases or fibrotic diseases. The wall becomes thick. So we have tropical endomyocardial fibrosis, so amyloidosis, hemochromatosis. Hemochromatosis is iron storage disease. And Fabry's disease, glycogen storage disease, all these are storage diseases. Amyloidosis is protein deposition. So these are the causes for restrictive cardiomyopathy. Hypertrophic cardiomyopathy we had discussed. So this is about cardiomyopathies and LV failure. So we just spoke about how to diagnose poor progression of R wave. So if there is poor progression of R wave, or when the patient has some symptoms like exertional breathing difficulty, poor exercise tolerance, paroxysmal nocturnal dyspnea. In these conditions, these are the symptoms for heart failure. That is, the heart is unable to do its pumping activity because of some structural changes in the heart. So based on ejection fraction, it is classified into two types: low ejection fraction or high ejection fraction. So normal ejection fraction, they are given the cutoff that when ejection fraction is less than 40%, it is heart failure with reduced ejection fraction. When the ejection fraction is more than or equal to 50%, it is called as heart failure with preserved ejection fraction. EF between 40 to 50, it is termed as heart failure with mid-range ejection fraction. I think this is more than enough to know. The most common cause for heart failure with reduced ejection fraction being coronary artery disease, post-MI. Of course, valvular heart disease can cause, infections can cause. So heart failure with reduced ejection fraction usually causes dilated cardiomyopathy, right? The same causes you can apply here. Heart failure with preserved ejection fraction, here we can think of restrictive cardiomyopathy. Heart will never dilate. So here again the cause is hypertension, obesity, hypertrophic cardiomyopathy. Now many cases of heart failure are actually heart failure with preserved ejection fraction. And remember, high output cardiac failure we discussed in aortic regurgitation and MR, mitral regurgitation. Conditions like thyrotoxicosis, anemia, beriberi, AV shunt, these diseases cause high output cardiac failure. Please remember HFrEF and HFpEF. So this again is commonly asked question. What are the 5 pillars of heart failure management? So the 5 pillars are ACE inhibitors or ARBs. Usually this ARBs are combined with neprilysin inhibitors. Neprilysin, they are
proteins which break down natriuretic peptides. When neprilysin is inhibited, natriuretic peptides are not broken down. So there is increased natriuretic peptides in the body which cause diuresis, which is good for the heart. So name some ACE inhibitors, anything which ends in pril, lisinopril, enalapril, captopril. ARBs is anything which ends in sartan, losartan, valsartan, candesartan, irbesartan. Now ARNI is, it's an angiotensin receptor blocker plus neprilysin inhibitor. So it's a valsartan plus neprilysin inhibitor is sacubitril. So the next pillar of heart failure management is mineralocorticoid receptor antagonist or aldosterone antagonist, eplerenone and spironolactone. Then we have beta blockers. So metoprolol, carvedilol and bisoprolol. And we have SGLT2 inhibitors. So this is the fifth pillar, dapagliflozin, empagliflozin. So we have other drugs also, hydralazine isosorbate dinitrate, digoxin. These are not pillars, they only reduce the symptoms. Okay. So at least know the 5 pillars of heart failure management. This is for heart failure with reduced ejection fraction. Now what about for heart failure with preserved ejection fraction? Many of these drugs cannot be used. The first drug which we use is SGLT2 inhibitor. Next, ARNIs have a role. That's all. Some studies say MRIs have a role. Maybe we'll delete off this. Only SGLT2 inhibitors and ARNIs have a role in heart failure with preserved ejection fraction. So that completes heart failure. Now coming to myocardial infarction or coronary artery disease. So this is the blood supply of the heart. Actually, it starts from epicardial arteries. They are the largest arteries. They divide into small arteries, arterioles and capillaries. What is visualized in coronary angiography is actually the epicardial vessels. But the epicardial vessels have the function of only transport. What is not visualized in coronary angiography is the coronary microcirculation. That is why patients who have problems in epicardial coronaries can be picked up in coronary artery disease, and it's usually called as coronary artery disease or the macrovascular disease. But microvascular disease is becoming more common nowadays. It presents as the same symptoms like a coronary artery disease, but coronary angiogram may be normal. So it is usually called as microvascular angina or MINOCA. MI with no obstructed coronaries, or INOCA, ischemia with no obstructed coronary arteries. So what is stable angina? So patient doesn't come to the emergency, but patient presents an exertional chest pain. There are 3 points to say stable angina. There is exertional chest pain. The character is retrosternal pricking type. Retrosternal compressing type. It's not pricking type, retrosternal compressing type. And relieved with rest or nitrates. This is the 3 criteria for stable angina. Why this is important is we have other types of pain like pleuritic type of chest pain. Pleuritic chest pain is not retrosternal, it is lateral in the axillary region. Then it is not exertional, it occurs with breathing. Deep breathing or coughing brings about the pain. It is a stabbing type of pain, it is not a compressing type of pain. And how it is relieved? By splinting, by lying on the deceased side. By lying on the side with pain, relieves pleuritic pain. So this is angina. Presence of stable angina indicates patient is having some coronary artery disease. But remember, here patient will not come to the emergency. But still, how will you evaluate? You are going to do an echocardiogram, electrocardiogram, echocardiogram. If the risk is high, we may do a treadmill test. Then we may do a coronary angiogram. If a patient is high risk, we will do a coronary angiogram. And Either you are going to give a medical management or we are going to revascularize. So this is the entire concept of coronary artery disease. So this diagram says about acute coronary syndrome. So we are not discussing about a patient who comes to the OP with a stable angina. We are discussing a patient who comes to the emergency with chest pain. So emergency with chest pain can be either unstable angina or it is N-STEMI or a STEMI. So how will you define the term MI? Presence of myocardial injury or infarction means there should be elevated troponin levels is the criteria. Okay, so even if you don't understand the other things, there should be a rise of cardiac troponin levels. So when there is a rise of troponin levels and there is a chest pain, based on whether ST is elevated or not, we say it is STEMI or N-STEMI. So what is unstable angina then? Patient is having exertional chest pain, but it is of increasing frequency. So patient is not stable. When do you say patient is unstable? There is angina, there is a retrosternal compressing type of chest pain, but it is not relieved with nitrates. It is not relieved with nitrates. It is increasing or crescendo in character, increasing in frequency or character. So in that case, we can tell that it is unstable angina. An unstable angina with rise in cardiac enzyme is called MI. With ST elevation, we call it as STEMI. With no ST elevation, we call it as N-STEMI. So what cardiac biomarkers do we want to send? So this chart is from biochemistry. The first marker which starts to rise is troponin, cardiac troponins. The next marker to start rising is CKMB. So the earliest and the best marker is troponin. So it starts to rise within 6 hours. So within 6 hours, troponin is the best marker. But see, troponin takes long time to settle. It takes a long time to disappear. So in case of recurrent MI, we cannot send troponin because if troponin is high, it doesn't mean patient is having a reinfarction. In that case, CKMB is the best option. So this is the cardiac enzyme which we send. So how will you treat STEM? Now that we know patient is coming with an acute coronary syndrome, he has STEMI, the time criteria is very important. We should take ECG within 15 minutes of arrival. Whatever is the emergency, we should take ECG within 15 minutes and we should plan intervention within 15 minutes. If it is STEMI and if it is a PCA capable center, PCA is percutaneous coronary intervention. Percutaneous coronary intervention is through a peripheral vessel, peripheral artery. We insert a catheter, we reach the coronary artery and we do some intervention. Either it is a stenting or lysis of the clot. That is percutaneous coronary intervention. For stable angina, not all cases we do CAG, but for acute coronary syndrome, all cases must receive coronary angiogram. So if a question comes or if a scenario comes, patient comes with acute coronary syndrome, you diagnose as STEMI or N-STEMI, the ideal procedure which has to be done is revascularization. Percutaneous intervention has to be done in every case. So if it is a PCA enabled center, within 90 minutes we have to insert the device. That is the criteria. So within 90 minutes in a PCA center, we have to do PCA. Suppose he comes to a non-PCA enabled center, definitely the option has to be to refer to PCA center. So again, a time delay will be there. So we can take an extra 30 minutes. So door in to door out from the non-PCA capable center should be less than 30 minutes. And within 120 minutes, he should receive PCI. So from the first medical contact to the referral and to doing PCI in that center, the entire time should be less than 120 minutes. Before that, we had to give fibrinolytic. Fibrinolytic It's also called as thrombolysis. It is the medical management of STEMI. So what was the earlier thrombolytic agent used? Streptokinase. Then we have recombinant tissue plasminogen activators. So what is plasminogen? Plasminogen is a substance which gets converted to plasmin. Plasmin is a substance which breaks down thrombin. We just discussed thrombin. Thrombin is formed from prothrombin, which helps to activate fibrinogen. So plasmin inactivates thrombin, right? So there are some proteins which activate plasminogen. They are called as tissue plasminogen activators. So recombinant tissue plasminogen activators are the second or the latest group of drugs. We have altiplase, retiplase, and tenecteplase. Only the dosage varies. Streptokinase is given as an infusion. Altiplase is given as an infusion. Retiplase is given as 2 doses 30 minutes apart. Tenecteplase is the best drug because it is a single dose. So what are the benefits of tenecteplase? One, it is a single dose. Second, it has high selectivity because when tissue plasminogen is activated, when plasmin is activated, it lyses clots everywhere in the body. So apart from cardiac thrombolysis, these drugs are also used in, like altiplase and tenecteplase alone are used in serious stroke thrombolysis. But the problem is, in a normal person with a high bleeding risk, giving these drugs can cause a cerebral bleed. The risk of cerebral bleed is more with streptokinase, less with tenecteplase. That is why tenecteplase is better preferred. So this has to be done and referred to the PCA capable center within 120 minutes. The first medical contact to device time should be there. What about NSTEMI? NSTEMI we must not thrombolyze. We must not thrombolyze because it is a vulnerable clot or a thin friable clot. It can embolize elsewhere. Whereas the clot in STEMI is a thick clot or a white clot. In NSTEMI it is a red clot. So this is about STEMI management. Some of these drugs we discussed earlier. So about antithrombotic therapy. So we'll just discuss how the sequence goes. Patient comes with STEMI. Patient comes with chest pain to the emergency. We do ECG within 15 minutes. It comes as STEMI. So what we do initially? We have to give loading dose. Whether it is unstable angina or in STEMI or STEMI, we have to give loading dose. So loading dose is usually 325 milligram of aspirin, 300 to 600 milligram of clopidogrel. This is usually given. Of course, prasugrel can also be loaded. Ticagrelor also can be loaded. If possible, you can remember the doses. So aspirin plus we are giving atorvastatin 80 mg. If it is an anterior wall infarct, we can give sorbitrate also, which is a nitrate vasodilator. These are some oral antiplatelets. We have some IV antiplatelet drugs also. They are cangrelor, eptifibatide and tirofiban. Need not remember the doses, just know the names. So we give loading dose and we plan for fibrinolysis if it is a non-PCA enabled center. If it is a PCA enabled center, we directly send them to PCA within 90 minutes. If it is a non-PCA enabled center, we do thrombolysis within 30 minutes and we immediately refer them so that they finally get PCA within 120 minutes. This is how the workflow. This is enough. This is more than enough to know. And you can read the loading doses. What if it is an NSTEMI, the same loading dose we are giving, but we are not doing a thrombolysis? We can do all other things except thrombolysis. We can give heparin. We can give low molecular weight heparin, which is enoxaparin. We can give fondaparinux. So about these drugs we discussed. And we discussed about oral anticoagulants also. So in some cases, oral anticoagulants are given along with antiplatelets. Don't get confused. Remember, antiplatelets are different from anticoagulants. Antiplatelets are different from anticoagulants. Remember, antiplatelets, function of platelets is aggregation and adhesion. Function of anticoagulation is to form a clot. So all the clotting factors come in the coagulation pathway, the platelet and von Willebrand factor, etc. come in the platelet pathway. So, okay. So just understand the difference. If possible, you can discuss later. What about anti-anginal agents? Remember, this chart is different from the previous chart. The statins, antiplatelets, anticoagulants, etc. are the actual treatment, the pathology changing treatment in MI. Whereas these are the anti-anginal drugs. That is the nitrates, beta blockers, heart rate lowering calcium channel blockers, that is non-dihydropyridine calcium channel blockers, ranolazine, and we have other second line drugs. Trimetazidine, ivabradine. So the first line drugs are beta blockers, nitrates, calcium channel blockers. These are the first line anti-anginal drugs. They do not change the pathology, they only reduce the symptoms. They do not change the pathology, they only reduce the symptoms. Remember, but we discussed beta blockers are the pillars of management in heart failure. But in angina, they do not change the pathology, they are only symptom reducing drugs. Second line drugs are ranolazine, trimetazidine and ivabradine. We discussed ivabradine is a funny current inhibitor. Trimetazidine is a fatty acid metabolism inhibitor. Ranolazine is a vasodilator. So these are second line drugs. Just introducing you to the concepts. Now what is CABG? Suppose we are doing a coronary angiogram and finding out that patient is, we have only 3 vessels, right? Cardiac anatomy, we have only 3 blood vessels. The right coronary artery, the left main coronary artery. The left main coronary artery divides into left anterior descending and left circumflex. There are so many branches, right? So there are only 3 blood vessels. There are only 3 epicardial arteries: right coronary artery, left anterior descending artery, and left circumflex artery. One important branch of right coronary artery is the posterior descending artery. If posterior descending artery arises from RCA, we call it as the right dominant system. If the posterior descending artery arises from the left circumflex artery, we call it as the left dominant system. If PDA arises from both, we call it as a codominant system. Okay. So if we do a coronary angiogram and find that one of the vessels is blocked, we usually go for percutaneous intervention. We place a stent like this. Suppose if there is a multi-vessel problem, 2 vessels or 3 vessels are diseased, usually we prefer CABG. So how can scenarios be presented to you? So patient can either come to the emergency with an acute coronary syndrome, or he can come to the OP with stable angina. So we take them for coronary angiogram initially. If there is a single vessel, we go for PCA and stenting. If there is multi-vessel, we go for CABG. Suppose if coronary angiogram is normal, still we cannot rule out MI because there are some other diseases like Takotsubo cardiomyopathy can present with chest pain, or stress cardiomyopathy. Myocarditis can present with chest pain. or what we discussed, the Minoca, MI with no obstructed coronaries, because the small vessels are usually affected here. So this finishes about MI. So we just started about the epicardial coronaries versus the small vessels. We discussed about acute coronary syndrome, STEMI versus NSTEMI pathway. We discussed something about antiplatelets, anticoagulants, and about PCA versus CABG. Suppose ECG is given about ST elevation. The basic fact to remember is ST elevation is not specific for MI. There are many causes which can cause ST elevation. At least remember two important causes. MI causes ST elevation. Acute pericarditis causes ST elevation. Even hyperkalemia, hypercalcemia can cause ST elevation. We discussed about hypothermia J wave or Osborn wave. Brugada syndrome, etc. they can cause ST elevation. Remember at least two causes, MI and acute pericarditis. So why there is ST elevation? Usually the vector goes from a normal myocardium to infarcted myocardium. So impulse goes from normal myocardium to infarcted myocardium. We have two types of myocardial infarction. One is subendothelial. So it's a subendothelial ischemia. The periphery is normal, only the subendothelial portion is infarcted. So since that is normal, vector goes towards the diseased area. So we get depression because it is going away from the surface. Whereas see here, when it's a transmural infarct, the vector goes from the surrounding normal myocardium towards the diseased myocardium. So there is ST elevation. Just a basic why ST elevation occurs, because of the vector direction. So we discussed two important diseases cause ST elevation. One is MA, another one is acute pericarditis. So suppose scenarios may be given where we have to diagnose which vessel is involved. Which vessel is involved, which wall is involved. So again, basic anatomy. So from the aorta, we have the right coronary artery. We have left main coronary artery, which divides into left anterior descending artery and left circumflex artery. What determines dominance? The posterior descending artery. If PDA comes from right coronary artery, it is right dominant. If PDA comes from left circumflex artery, it is left dominant. If PDA arises from both, it is called codominant. So you can very well see what does the right coronary artery supply. Right coronary artery supplies the right side of heart, as well as the inferior wall. What does the left anterior descending artery supply? It supplies the entire anterior wall and the septum. Supplies the entire anterior wall and the septum. What does left circumflex artery supply? It supplies the high lateral wall. Supplies the high lateral wall. So we discussed about the normal vector direction as 60 degrees in the normal ECG. See, this is how ECG leads are placed, right? So the chest leads are placed like this. V1 is to the right side of the sternum, so it sees the right side of the heart. V2, V3, V4, they are straight anterior to the heart. So V2, V3, V4 see the anterior wall of the heart. V5, V6 is lateral, so it sees the lateral wall of the heart. Right? V1 is right, V2 to V5 is anterior wall, V5 and V6 is lateral wall. So you can see the vector direction here, right? So lead to the normal direction goes like this. You must remember the axis direction. Lead AVL, the axis is minus 30 degree. AVF, the axis is 90 degree. Lead 3 is 120 degree. That is, lead 1 is 0 degree, at 60 degree everywhere. Lead 1 is 0, lead 2 is 60, lead 3 is 120. For the augmented leads, draw in between. So lead AVL is minus 30, lead AVF is 90, and lead AVR is plus 210, or if you come in the negative, it is minus 150 degrees. Okay, so the normal heart follows the axis of 60 degree. The normal heart's axis is 60 degree. Okay, so you can very well see lead 2, lead 3, lead AVF face the inferior wall of the heart. AVL and lead 1 see the lateral wall of the heart, right? So this may be difficult to remember. People who are used to ECG can try to remember. Among the chest leads, V1 sees the right side of the heart, V2 to V4 see the anterior wall of the heart, V5, V6 see the lateral wall of the heart. Among the limb leads, lead 2, lead AVF, lead 3 see the inferior wall of the heart, lead 1 and lead AVL see the lateral wall of the heart. This is the same diagram. Actually, if V1 shows some changes, we are supposed to see the right-sided heart leads. That is, the normal ECG which we see is 12 lead ECG, 6 limb leads and 6 chest leads. If we are suspecting a RV infarction, right ventricular infarction, like patient is having a conduction disturbance, this we discussed. Right ventricular infarction causes AV blocks. So patient is having a conduction disturbance, or there is a severe hypotension, because we have to give plenty of fluids in right ventricular infarction, because only the right ventricle has to pump blood to the pulmonary circulation and that has to enter the left side of the heart. So severe hypotension or severe conduction disturbance without pulmonary edema, we should always think of right ventricular infarct. RV infarct is usually associated with inferior wall myocardial infarction, because right wall and inferior wall both are supplied by the same artery. So usually they two come together. So if there is an inferior wall MI or if RVMI is suspected, we should take right ventricular MI, right ventricular leads, right-sided leads. V4R is very important. We also have posterior leads. So these are extended leads. Okay. So which wall, which disease? So right coronary artery supplies the right side of the chest and inferior wall. So it causes right ventricular MI plus inferior wall MI, and there can be posterior wall MI also, diagnosed by posterior wall leads. So where all you can find the changes? Lead 2, lead 3, AVF there will be elevation. RVMI is diagnosed by V1 changes plus posterior wall. If we cannot see the posterior wall, when posterior wall is elevated, what is straight in front of the posterior wall? The anterior wall. So V2, V3 will be depressed, right? So ST elevation in lead 2, 3 AVF is inferior wall MI. V1 elevation is RVMI. Lead or the V4R, the right sided lead V4, when it is elevated, it is RVMI. When V2, V3 is depressed, we can see that there is an elevation in the posterior leads. There are some elevation criteria, like how much it should be elevated. What should be it for a chest lead, what should be it for a limb lead, what should be it for a male. So you can read it. I am just telling the basics here. So LAD, left anterior descending artery, supplies the anterior wall and septum. So what does it see? Lead V3, V4 mainly. And what about LCX? It supplies lead 1, AVL, V5, V6. So it is lateral wall MI. So ECG may be given. So once you diagnose it as STEMI, try to find out which leads there is elevation and try to think of the axis and try to say what wall is involved, what vessel is involved. Okay. So among causes of ST elevation, we finished discussing about the myocardial infarction ST elevation. Another condition which causes ST elevation is acute pericarditis. Pericarditis is inflammation of the pericardium. How will you differentiate ST elevation of MI versus ST elevation of pericarditis? ST elevation of MI will have an elevation like this. It's a frowning elevation. Whereas pericarditis will have an elevation like this. It's a concave upward elevation. It's a smiling elevation. So pericarditis is not that dangerous. MI is dangerous. This is called as the tombstone pattern. Okay. So you can see here, there is ST elevation everywhere. In MI we told ST elevation will be only localized, like whether it will come only in the inferior wall or lateral wall or right ventricle. But here you can see there is generalized ST elevation, plus you can see it is a concave upward elevation or a smiling elevation. So whenever there is ST elevation, don't jump to the diagnosis of MI. Think of the quality of chest pain. Myocardial infarction will be compressing chest pain. Here it will not be a compressing chest pain. Pericarditis will be a pleuritic type of chest pain. Okay, it will be a pleuritic type of chest pain relieved on leaning forward. So that's generalized ST elevation, concave upward elevation. And there is also PR segment depression. See here, it's not only ST elevation, the PR is depressed, you can see. So PR depression, generalized ST elevation and a concave upward elevation. This is the triad of acute pericarditis. In the later stage of pericarditis, there may be T wave inversion. Okay. So based on the duration, pericarditis can be acute pericarditis less than 6 weeks, subacute pericarditis 6 weeks to 6 months, and chronic pericarditis. One type of chronic pericarditis is constrictive pericarditis. So again, etiology, so many reasons. It could be infections like viruses, it could be idiopathic. Rheumatic fever can cause pericarditis. Rheumatic fever can cause all the three. It can cause endocarditis, myocarditis and pericarditis. Endocarditis causes valve problem, myocarditis causes heart failure or tachycardia or S3, and pericarditis, it can cause pericardial rub. So the finding of pericarditis is pericardial rub. And post cardiac injury, post MI, there can be post MI pericarditis called Dressler syndrome. So what are the drugs which are given? We can give NSAIDs, we can give colchicine, uremic pericarditis also. So this finishes the entire ECG based cardiology discussion. So we discussed about arrhythmias, we discussed about valvular heart diseases with P wave, we discussed about ST elevation and depressions. Now the last two small concepts, the JVP. So JVP, normal JVP as, so what is JVP is jugular venous pulse. It is a transmission from the right atrium. So any pressure in the right atrium is transmitted to the internal jugular vein, which we see clinically as the JVP. So JVP has 5 waves, 3 positive waves and 2 negative waves. Positive waves are A and C and B, and the negative waves are X descent and Y descent. So this is the one. A, C are the positive and B are the positive waves, and we have X descent and Y descent are the negative waves. So correlate this with the cardiac cycle. Okay. So what is A wave is atrial contraction. A stands for atrial contraction. Atrial contraction is atrial systole. We told atrial systole occurs in the last 0.1 seconds of the ventricular diastole. What is the function of atrial systole? To pump blood from the atrium to the ventricle. It pumps the last bit of blood from the atrium to the ventricle. So when the right atrium contracts, it transmits its pressure to the internal jugular vein, and it is seen as the A wave in JVP. So atrium contracting, the tricuspid valve open. That's the reason for A wave. So when does A wave increase? When the right atrium has to pump against pressure of the tricuspid valve. So it increases in tricuspid stenosis or right ventricular hypertrophy or pulmonary stenosis or pulmonary hypertension. In these conditions, A wave will be prominent. So we have few conditions like giant A wave, Canon A wave. Canon A wave occurs in heart failure, heart block, complete heart block. Because of the AV dissociation, atrium contracts separately, ventricle contracts separately. So since they both contract separately, the blood from the atrium never reaches the ventricle. So the atrium will have a very large pressure. That's what is called as Canon A wave. Occurs in complete heart block. Can remember it as a one-liner. So what is C? So after atrial contraction, blood empties into the ventricle. Now ventricle is full. So since diastole ends now ventricle goes for isovolumetric contraction. So the tricuspid valve close. The tricuspid valve closure causes a pressure wave in JVP. It is called C wave. It is not clinically significant. So after this, what happens? After isovolumetric contraction, blood from the ventricle empties into the aorta. So left ventricular pressure decreases. So now the tricuspid valve comes down. So because of this, because of the descent of the tricuspid valve, we get X descent. So X descent occurs when the ventricle relaxes and the tricuspid valve descends. After this, what happens? When the tricuspid valve descends, atrium is also relaxing. So blood from the IVC and SVC come into the right atrium and atrium starts filling. So this venous filling leads to V wave. So after this, what happens? When the atrium is now full, diastole starts. Right? When diastole starts, isovolumetric relaxation occurs, the tricuspid valve opens. So when tricuspid valve opens, blood starts emptying into the ventricle from the atria. So now atrium will lose its pressure. So that is Y descent. So Y descent is due to atrial emptying. So A is due to atrial contraction before ventricular systole. C is due to the closure of the tricuspid valve. X descent is the relaxation of the atrium or descent of the tricuspid valve during ventricular relaxation. V is the venous filling of the atrium, and Y descent is the emptying of blood into the ventricle during ventricular diastole. We have to know the entire ECG for diagnosing A wave. So we discussed about A wave disorders. Where does V wave help? V wave is prominent in tricuspid regurgitation. So why tricuspid regurgitation V wave is prominent? Because in tricuspid regurgitation, blood goes from the right ventricle to the right atrium during contraction. So V wave will be very prominent here, right? So already blood is getting full, plus because of the regurgitation, the atrium is already full. So venous filling of the already full right atrium is the reason for V wave prominence. So that is about the V wave. Now X descent and Y descent, we have to remember for two important diseases: cardiac tamponade versus constrictive pericarditis. Remember, constrictive pericarditis and restrictive cardiomyopathy both present similarly. So you can see the differences here. Cardiac tamponade is a disease where fluid gets accumulated around the heart to cause compression of the heart. So there will be collapse of the ventricle and atrium during diastole. This is the pathogenesis of cardiac tamponade. It is an emergency. Here patient presents with hypotension, elevated JVP and distant heart sounds. The same presentation will occur in pneumothorax. So In constrictive pericarditis is one type of chronic pericarditis where there will be calcification of the pericardium. Example, tuberculosis. So main important thing is what happens to the X descent, what happens to the Y descent. I always say the mnemonic, think of the mnemonic, pay tax. In pericarditis, Y and X descent both are prominent. In constrictive pericarditis, X descent and Y descent both are prominent. In cardiac tamponade, X descent alone is prominent. Okay. So if you think of the pathogenesis, you can understand. Why Y descent is absent in cardiac tamponade? Y descent is due to emptying of blood from the atria to the ventricle. But ventricle is collapsed during diastole in cardiac tamponade. So blood does not empty from the ventricle, from the atria to the ventricle during Y wave. That is why it is absent. Why X descent and Y descent are prominent? Because the pericardium or the constricting pericardium or the fluid around the cardiac, the fluid around the heart makes the ventricle less compliant. So because the ventricle is less compliant, the pressure difference will be very obvious. So X descent is very prominent. So at least if you remember, Y descent is absent in cardiac tamponade, that is enough. So why Y descent is absent in cardiac tamponade? Because the ventricle is not filled during diastole, right? And we have one BP finding in cardiac tamponade, which is pulsus paradoxus, which is fall in blood pressure of more than 20 millimeters of mercury during deep inspiration. And what sound do we hear in cardiac tamponade? We do not hear sound in cardiac tamponade. In constrictive pericarditis, we hear pericardial knock. In pericarditis, we hear pericardial run. Okay. So remember pay tax. In constrictive pericarditis, Y and X descent both are prominent. In cardiac tamponade, only X descent is prominent and Y descent is absent. Coming to the last part, aortic dissection. It's a vascular disorder. Aortic dissection is where the blood pierces the endothelium of the aorta and it creates a pseudovascular lumen and it causes hypotension. So there are two types of classification, Stanford and DeBakey classification, Stanford A and we have Stanford B. Stanford A is A for ascending aorta. So Stanford A is ascending aorta is always involved. Stanford B is aortic ascending aorta is not involved. So only the descending aorta is involved. We have DeBakey's classification. DeBakey type 1 is both ascending aorta and descending aorta is involved. DeBakey type 2 is only ascending aorta is involved. Type 3 is only descending aorta is involved, right? So Stanford A and B, A is ascending aorta involvement, either both ascending and descending aorta is involved or only ascending aorta is involved. Type B is only descending aorta is involved. So DeBakey type 1 is both ascending and descending aorta, type 2 is only ascending aorta, type 3 is only descending aorta. When ascending aorta is involved, the treatment is surgery. It's an emergency. When descending aorta is involved, we can go for medical management by BP control and we can wait. And we do surgery only in elective cases. So A is ascending aorta. Suppose if image is given, they ask the treatment. Ascending aorta is involved, treatment is surgery. Descending aorta is involved, we can wait. Right? So this finishes our entire cardiology discussion.